diving right in today. We're going deep on optic neuritis. I mean, super relevant for all of us. Right?
Oh, absolutely. Can't really practice ophthalmology without bumping into this one.
Nope, not a chance. So we've got this pretty amazing neuro-ophthalmology text we're pulling from, trying to get to the core of it. What are we actually seeing in clinic? What's causing it? And how do we manage these patients? The stuff that matters day to day.
Exactly. Think of it as a optic neuritis cheat sheet, tailored for, well, us. What we need to know, what we need to do.
Love it. So mission of this deep dive then, let's lay it out.
Okay, so goal is to give every ophthalmologist listening that crystal clear understanding of optic neuritis. How does it present? Why is it happening? What are our options for treatment? Not just theory, though. This is about walking out of here ready to diagnose and handle these cases with, total confidence.
I'm in. Let's do it. So first off, how do we even classify this thing? I mean, based on what we're seeing, in the exam room, the text breaks it down nicely into 3 main types, all based on, well, what the optic disc looks like. So retrobulbar neuritis, let's start there.
Yeah.
Clinically, what's the big takeaway? What's that one thing we can't miss?
Okay, so with retrobulbar neuritis, get this. The optic disc can look totally normal, at least at first. Because the inflammation, it's happening further back behind the eye. The nerve head itself isn't involved at the beginning. So massive point for us, right? You've got an adult patient complaining of vision loss, but their optic disc looks fine. Huge red flag for retrobulbar neuritis. And then, of course, you got to think about that possible MS connection.
Can't forget that MS link. So normal disc doesn't rule out optic neuritis. Got it. Now, what about papillitis? What are we seeing there when we look through the ophthalmoscope?
Okay, papillitis. Totally a different story. Here, the optic disc is definitely inflamed. You'll see a hyperemia, so it'll look redder than usual, and edema, so it's swollen. The text even mentions you might see some peripapillary hemorrhages, those little flame-shaped bleeds, and maybe even cells floating around in the posterior vitreous. So unlike retrobulbar, the inflammation's right there, plain as day.
Way more obvious. And the patient demographics are interesting too, right? It's not the same across the board.
Oh, for sure. Papillitis, it's actually the most common type we see in kids. So young patients, sudden vision loss, acutely swollen disc, think papillitis, high on your list, but, and this is key, adults can definitely get it too.
So age isn't everything. Got it. Neuroretinitis. Last one, based purely on looks. This sounds like a bit of a hybrid, right? What's the tip-off here? What should make us think neuroretinitis?
You're right, it does combine features. So you've got the papillitis picture, red swollen disc, but then you add in the retinal piece, inflammation of that retinal nerve fiber layer, the RNFL, and this, a macular star. That star figure is almost like a signature finding.
It's very classic, yeah. Almost pathognomonic, right? Like, if you see that, boom, neuroretinitis.
Pretty much. And 2 big things to remember clinically. First, neuroretinitis, it's the least common of the 3. And second, big difference, it's almost never from demyelination, unlike retrobulbar and sometimes papillitis. So that star, it points you toward a whole different set of causes.
Okay, so that's what we're seeing. But we both know it's the why that really guides our decisions. So the source goes on, breaks down optic neuritis based on, well, what's causing it. The etiology.
Yeah.
And no surprise, right? Demyelinating, that's our most common culprit.
By far, yep. And just understanding that basic demyelination process, it's super important. We're talking about damage to that myelin sheath, the insulation around our nerve fibers. It's like stripping the coating off an electrical wire. Signal gets messed up. In the visual pathway, that demyelination, it disrupts how that visual information gets from the eye to the brain, hence the symptoms.
Makes sense. So parainfectious optic neuritis, that's next on the list. Clinically, what does that look like for us?
Okay, so this is where things get kind of interesting. Parainfectious, it usually pops up after a viral infection or even a vaccination, usually within a few weeks. And it's especially common in kids. Often, they present with sudden, severe vision loss in both eyes, plus bilateral papillitis. So think, young patient, recent flu-like illness, or maybe just got a vaccine, and then bam, this picture. Parainfectious should be high on your radar.
And the good news with the parainfectious cases, especially in kids, is that the prognosis is generally good, right?
Yeah, usually they recover pretty well on their own, even without treatment. But of course, there are exceptions. If that vision loss is really profound, or it hits both eyes really hard, or maybe it involves the only eye they can see out of, then you've got to consider treatment. Maybe a short course of steroids, IV, possibly some antivirals too. And getting a good history is key here. The source lists a whole bunch of potential culprits. Measles, mumps, chickenpox, rubella, whooping cough, even glandular fever. So, recent illnesses, ask about them.
Lots to consider. Infectious optic neuritis. Let's get into that. Here we're talking about, well, actual pathogens attacking the nerve, right? What are some prime examples we should be ready for?
All right, so this category, it's got a bunch of different players. One that the source mentions is sinus-related optic neuritis. Not super common, but it can cause these recurring episodes of vision loss, usually in one eye, with a bad headache. And you'll see signs of that sphenoethmoidal sinusitis. Could be direct spread of the infection, or maybe inflammation of the blood vessels, or even pressure from a mucosilla. What do? Systemic antibiotics, and maybe a referral to an ENT for drainage if it's needed.
So atypical one-sided vision loss comes and goes, bad headache. Got to think beyond the usual suspects, consider those sinuses.
Yeah.
What else is on that infectious list?
Cat scratch disease, that's a big one for us, caused by Bartonella henselae. And guess what its main eye symptom is? Neuroretinitis. So if you've got neuroretinitis in a patient and they've been around cats, definitely think about that. Then we've got syphilis, can cause acute papillitis or neuroretinitis, especially during the primary or secondary stages. Risk factors, those are always key to keep in mind. Lyme disease from those tick bites, that can also lead to more retinitis. And sometimes even retrobulbar neuritis that looks a lot like MS. So if you're in an area where Lyme's common and the patient's been outdoors, put it on your differential.
Wow, so many different bugs can hit that optic nerve.
Yeah, it's wild. And the source also talks about cryptococcal meningitis, especially in immunocompromised patients, like those with AIDS. That can cause acute optic neuritis, sometimes in both eyes. And then there's varicella zoster, the chickenpox virus. It can cause papillitis, usually by spreading from a retinal infection, like acute retinal necrosis or progressive retinal necrosis, or maybe it comes with herpes zoster ophthalmicus. Primary optic neuritis from VZV, it's less common, but it happens, especially in those with weaker immune systems. They might develop that rash or retinal findings later on.
So the takeaway is we got to think big picture. Complete history, understand their medical background, all that. Okay, non-infectious causes. Sarcoidosis, that's one the source brings up. What are the key signs for us? What should we be looking out for?
Yeah, so sarcoidosis, it's a systemic inflammatory disease, and it can impact the optic nerve. It's not a huge percentage of neurosarcoidosis patients, but it's definitely something we see. And sometimes, get this, optic neuritis is the first sign, the thing that actually leads to the diagnosis. Ophthalmologically, you might see a lumpy optic nerve head because of that granulomatous infiltration. And there could be vitritis too. Good news is it usually responds well to steroids. But it can come back if you taper those steroids too fast. Some patients might need them long-term, low dose, or maybe other immunosuppressants like methotrexate, just to keep things under control.
And the last non-infectious category they mentioned, systemic autoimmune diseases. What are we thinking about here? What conditions come to mind?
Exactly. Things like lupus, polyarteritis nodosa, and other vasculitides. Basically widespread inflammation in the body. Those can also be tied to optic neuritis. So if you've got a patient with a known autoimmune disease and they present with optic neuritis, well, it could be part of that bigger picture.
Another reminder to think beyond the eyes. Okay, let's zoom back in on demyelinating optic neuritis, our most frequent offender. The source gets into some good detail here.
Yeah, and it all comes back to that demyelination process. Loss of that myelin sheath, the insulation that lets those nerve signals travel quickly and efficiently. When that sheath gets damaged, it's like hitting the brakes on that visual information flow. And that demyelination, it triggers a whole immune response. Cells come in, clear out that damaged myelin, and astrocytes form scar tissue. Those are the plaques we see in conditions like MS.
And the source goes through a few demyelinating conditions that can mess with our vision, with isolated optic neuritis being a big one we see all the time.
Right.
So what's the bottom line for us with these patients? What's the message we need to remember?
Key point here, right? Patient comes in, classic optic neuritis, but no other obvious neurological signs. Well, here's the thing. A good chunk of them, we're talking like 50% over 15 years, they're going to develop MS down the road. So monitoring, counseling, those are huge.
Definitely a sobering thought. Okay, MS itself. We know it can really impact the eyes. So beyond the optic neuritis, what are some of the other systemic things we should be looking out for? What else might these patients experience?
Okay, so MS, it's an idiopathic demyelinating disease, mainly targeting the white matter of the central nervous system. And Interesting fact, infection with Epstein-Barr virus, it really ups the risk of MS. Not the only cause, but definitely a big factor. And it's more common in women, it usually shows up in their 30s or 40s. Typically, you see this relapsing remitting pattern of neurological symptoms. Systemically, this can involve the spinal cord, causing weakness, stiffness, problems with bladder or bowel control. Brainstem involvement can lead to double vision, nystagmus, trouble speaking or swallowing. And cerebral involvement, well, that can cause all sorts of motor or sensory deficits, even cognitive and mood changes. Some patients, they might also experience transient symptoms like Lermit's sign, that weird electrical sensation down the spine when they bend their neck, or Euthos phenomenon, where symptoms get worse with heat or exercise.
That's a lot of potential issues. Now, for us as eye doctors, what are we looking for besides the optic neuritis itself? What other eye-related signs might we see in our MS patients?
Well, optic neuritis, especially that retrobolder type, that's super common, as is internuclear ophthalmoplegia, which affects those side-to-side eye movements. And nystagmus, too. Less common findings would be skew deviation, ocular motor nerve palsy, so their eyes aren't aligned properly, and hemianopia. And then rarely you might see intermediate uveitis or retinal paraphlebitis. So bottom line, even if it seems like isolated optic neuritis, it could be the tip of the iceberg, the first sign of something much bigger.
Really emphasizes the importance of that thorough exam. Okay, so let's say we suspect a demyelinating condition. What tests are we ordering? What's going to help us and our neurology colleagues nail down that diagnosis?
All right, investigations. Super important here. Lumbar puncture that can show oligoclonal bands in the cerebrospinal fluid, which is a big clue in MSMRI, that's essential. Brain and spinal cord. It can pick up changes in the optic nerve, especially on those STIR sequences. And of course, it can show those classic white matter plaques disseminated in space and time. That's a hallmark of MS visual evoked potentials, VEPs. Those can also be helpful. They measure the electrical activity in the visual pathway, and they can show a delay or reduced amplitude in a lot of demyelinating conditions, even when the optic nerve seems fine clinically.
These tests really help us get complete picture. Now let's go back to that optic neuritis MS link. This is key information for our patients. So what are the numbers? What's the risk?
Okay, so overall, the risk of developing MS within 15 years of having optic neuritis, it's about 50%. But, and this is a big but, whether or not there are lesions on that initial brain MRI, that's a major predictor. If that MRI is clean, the risk drops way down to about 25%. But if there are one or more lesions suggesting demyelination, the risk jumps to over 70%. So that first MRI is absolutely crucial for figuring out the risk and guiding how we talk to our patients.
Wow. Yeah, that initial MRI really makes a difference. Are there any other signs right when they present with the optic neuritis that might suggest a lower risk of MS, even if the MRI shows lesions?
You know, there are actually a few things that can point to a lower risk even with those MRI lesions. Being male, if they didn't have a virus right before the optic neuritis, a negative test for Epstein-Barr, if their optic disc was swollen or had those hemorrhages or exudates, if their vision loss was really bad at first, like down to no light perception, and if they didn't have any pain around the eye. So those are all things we can consider when we're trying to figure out an individual patient's risk.
It's like putting together a puzzle, right? Lots of pieces.
Yeah.
And how often is it that optic neuritis is the very first sign that someone has MS?
It's actually the first symptom in up to 30% of cases. And over the course of the disease, about half of all MS patients will experience at least one episode of optic neuritis. But it's important to remember, even when it's tied to MS, vision usually gets better over time spontaneously for most people.
Okay, good to know. Let's talk about what demyelinating optic neuritis looks like clinically. What are those telltale symptoms that bring patients into our office? What are they complaining about?
Classic presentation. Subacute vision loss in one eye comes on gradually over days or weeks. Typically, patients are between 20 and 50 years old. A lot of them describe seeing phosphenes, those flashes or shimmering lights. And here's the big one. Over 90% of them will complain about pain in or around the eye, especially when they move their eyes. That pain can even start before the vision loss. Some might also have a bit of a headache in the front of their head or tenderness when you touch their eyeball. So if you see that combo, subacute vision loss, pain when they move their eyes, maybe some phosphenes, that's a big red flag for demyelinating optic neuritis.
So what are we seeing when we examine them? What are those key signs?
Visual acuity, it's almost always down, somewhere between 20/40 and 2200, though it can be worse. You'll usually find other signs of optic nerve dysfunction too, like their color vision might be off, often more than you'd expect based on their Snellen acuity, and they might have a relative afferent pupillary defect. Now remember, About 2/3 of the time, that optic disc will look totally normal. That's that retrobulbar neuritis we talked about. The other third, you'll see papillitis. And sometimes you'll see this subtle pallor of the optic disc on the other side, the unaffected eye. That could mean they had a previous episode of optic neuritis. Maybe they didn't even notice it.
And what about their visual fields? What kind of defects are we seeing in demyelinating optic neuritis?
The most common thing we see is a generalized depression of sensitivity in the central 30 degrees of their vision. But you can also see altitudinal or arcuate defects. Those respect the horizontal midline. And sometimes there are focal scotomas in the central or centrocecal area, often with that background of generalized depression. So basically you can see all sorts of field defects, and that reflects the patchy nature of demyelination.
So their vision gets worse, then it starts to get better. What's that recovery process usually look like? How long does it take?
It usually keeps getting worse for about 3 weeks, max. Then it turns around and starts to improve. Most patients, they'll see a big improvement in the first month, fast at first, then more gradually over the next 6 to 12 months. Important thing is, set realistic expectations. Let them know it can be a while.
And long term, what's the outlook? How's their vision going to be down the road?
Good news is more than 90% of them will end up with visual acuity of 20/30 or better. But they might still have some subtle problems, like their color vision or contrast sensitivity might not be perfect. And a mild RAPD can stick around too. Sometimes you'll see some temporal pallor on the optic disc, maybe even a little atrophy. Unfortunately, about 10% of patients will have vision loss that's more chronic, slowly gets worse over time, or comes and goes.
So we've talked about the MS risk. What do we do after a patient presents with demyelinating optic neuritis? What are our management priorities?
Okay, well, first things first. MS risk is high, like we said. So get them to a neurologist, stat. They need to be evaluated for disease-modifying therapies, those DMTs. Those drugs, they can really help lower the frequency of MS attacks, maybe even slow down disability progression. But, and it's a big but, you've got to talk to your patients about the potential side effects. These drugs, they're not without risks, and they need to be monitored carefully by a specialist.
And steroids, what's their role? When are we using them in these optic neuritis cases?
Steroids, specifically intravenous methylprednisolone, given within 48 hours of when symptoms start, they can potentially protect those axons and maybe even lead to better vision in the long run. They can also speed up that initial recovery by a couple of weeks, and they might delay when clinical MS actually develops, especially if their vision is worse than 20/70 in that first week. But you've got to weigh those benefits against the risks of giving high-dose steroids, especially if the other eye is seeing well.
So what's the usual steroid regimen? What are we doing?
Standard approach is IV methylprednisolone, high dose, for 3 days. Then they switch to oral prednisolone, which gets tapered off over about 2 weeks. Really important point here. Oral prednisolone alone, without that initial IV push, it's actually been linked to a higher risk of recurrent optic neuritis. So the IV route, that's usually the way to go if the patient can tolerate it.
Good to know. So for those high-risk patients, the ones who do end up with MS, what are some of the disease-modifying therapies they might be starting?
Oh, there are a lot of options out there and more coming all the time. Interferon beta, that's often used early on. It's got a pretty good track record safety-wise. Glatiramer acetate, that's another option, can reduce those relapses. And then there are the monoclonal antibodies like natalizumab, ocrelizumab, and elintuzumab. Those are usually reserved for the more aggressive forms of MS because they can have some systemic side effects. Natalizumab, for example, it's great at lowering relapses and slowing down disability in relapsing remitting MS ocrelizumab. That's shown benefits in both relapsing remitting and primary progressive MS. And lonituzumab, because you don't have to give it as often, it can be a really good choice, cost-wise.
It's really a team effort, isn't it? We're working with the neurologists and other specialists to figure out the best approach.
Oh, absolutely. We need to be talking to each other. It's all about that collaboration. For a first attack that looks like MS, usually it's IV steroids, then maybe interferon beta or glatiramer acetate. For patients with relapsing MS, the treatment depends on how active the disease is. Could be just monitoring, or it could be those more aggressive DMTs. And for the progressive forms of MS, ocrelizumab, that's a big player right now.
Okay, neuroretinitis. We've touched on it, but let's circle back. Important stuff for us. So remind us, what are the main things we need to know to diagnose it and manage it properly?
All right, neuroretinitis. It's that combo of optic neuritis and retinal inflammation usually hitting the macula. Cat scratch fever, that's the most common cause we can pinpoint, about 60% of cases. But a lot of them, they're idiopathic. That's Leber's idiopathic stellate neuroretinitis. Other infectious causes to think about: syphilis, Lyme, mumps, leptospirosis.
And how are these patients presenting? What are they telling us?
Usually it's painless vision loss in one eye, comes on gradually over a week or so. Visual acuity can be all over the place, and you might not see strong signs of optic nerve dysfunction because a lot of the vision loss is coming from that macular edema. On exam, you'll see papillitis with swelling around the disc and in the macula. That classic macular star, it often becomes more obvious as the disc swelling goes down. In severe cases, you might see engorged veins and those splinter hemorrhages, and sometimes the other eye gets involved too.
What tests help us make the diagnosis and figure out what's causing it?
OCT, that's going to show us the fluid in and under the retina. Fluorescein angiography, that can show us leakage from those superficial disc vessels. And then super important blood tests, especially serology for Bartonella henselae and any other infectious agents we're considering. Got to nail down that cause.
And how do we treat neuroretinitis? What's our plan of attack?
Treat the cause, that's the main thing. If it's infectious, like cat scratch or Lyme, antibiotics, that's your go-to. If it's idiopathic and keeps coming back, you might think about steroids or other immunosuppressants. Good news is that macular star usually fades away after a few months, and vision often goes back to almost normal.
Wow, this deep dive has been jam-packed, super thorough, and so clinically relevant. Just to recap, we talked about how it looks, those ophthalmoscopic classifications.
Right.
Central bulbar neuritis, often with a normal disc, papillitis with that visible swelling, and neuroretinitis with that telltale macular star. Then we went through the causes, demyelinating being the most common, then parainfectious, infectious, and non-infectious.
And that link between demyelinating optic neuritis and MS, that's huge. Early MRI, other clinical factors, those are crucial for figuring out the risk. We also went over how important it is to make the diagnosis quickly, recognizing those key features and knowing what to do, when to use steroids, when to send them to neurology for those disease-modifying therapies.
So here's something to think about. For all you amazing ophthalmologists out there, we've got this wide range of causes for optic neuritis. And some of them, especially those demyelinating cases, they can have serious neurological consequences down the road. So how are you integrating all this information into your daily practice? How are you using it to make sure your patients are getting the best possible care? How are you making those crucial referrals? How are you identifying those patients who need a neural workup, who might benefit from those disease-modifying drugs? Optic neuritis, it's a complex beast, but your skills, they're absolutely critical for protecting both their vision and their neurological health. Thanks for joining us on this deep dive.